Israel, so she's on Israeli time. And she is in Maine right now.
Yeah. Okay. I'd like to welcome Elizabeth Crampsey. She came in Friday night. She's had a couple days to get oriented and get situated. I've been pleased to work with her, and she's ready to start her presentation.
So it is my pleasure to be here today, and thank you for being here for my milestone. I know how busy spring is in my life, so I can only imagine it's also busy in yours. So my dissertation was Occupational Therapy Students' application of the Interprofessional Education Core Competency Domain Simulation. So interprofessional education, or IPE, is a strategy that we think is part of the solution for basically contemporary healthcare today. We know it's complex and it's team-based, but we also know it's driven by quality and cost effectiveness. It is a contemporary, current, and innovative health education tool that we hope is replacing the outdated silos where we just learn discipline-specific tools, but with IPE we can enhance that education. It's a method where at least two professionals learn from, with, and about one another, and the purpose is to improve team collaboration and quality of healthcare. So on campus, we hope students get a chance to practice team-based and collaborative skills. We know that students seek and find value in those hands-on experiential case-based learning experiences. And through IPE, they can become workforce ready and prepared for the sophisticated and fast-paced health environment. Each of the health professions has their own IPE standards at this point, and OT, or Occupational Therapy, formally established theirs in 2011. So this study was a content analysis of a specific IPE program that was team-based and included a healthcare simulation, or SIM IPE, called IPTE, or the Interprofessional Team Immersion. So this study assessed OT students' application of the IPE core competency domains during the healthcare simulation. Well, a little bit about my organization. It is the largest private university in Maine and the largest educator of health professionals within the state. It's considered small, educational, and a nonprofit university that's organized into 6 colleges with campus-based and online programs with over 70 programs of study. We have 3 campuses, 2 are in Maine and 1 is in Morocco. IPEC was formally established at our university in 2010, which really solidified the commitment to educating the future generation of healthcare providers that are well-equipped for team-based practice.
I lost sound. can't hear it all.
Hello.
Hello, can you hear me?
There.
Okay,
Okay.
we're good? Welcome back. Okay. Okay.
You're a rock star.
Thank you, Shannon.
You
did it.
No panic or anything.
Okay, so picking back up, I wanted to address what the U.S. IPE core competencies are, and there are 4 of them. Their values and ethics, roles and responsibilities, interprofessional communication, and teams and teamwork. And these were updated from 2011 to 2016, and they're much more specific and more broad to include public health concerns as well. And underneath all 4 of these are many other sub-competencies. So the purpose of the study was a content analysis to gain deeper understanding into the application of IPE core competency domains during IPE team immersion experience on campus at a private nonprofit university, specifically the scope related to what extent OT students were applying those core competency domains during that simulation. So the research question that guided the content analysis was, to what extent did OT students apply the IPE core competencies during on-campus IPE team immersion simulations for health professional students? So the aim of the study was to both assess and inform our own institution as well as others how to both strengthen and sustain interprofessional learning through sim-IPE experiences, and about the influence of learning and applying the IPE competencies during the team case-based healthcare simulation. I hoped that there would be generalizability to other institutions and OT programs. So as you can imagine, there's a fair amount of information out there about IPE. So my selected literature review focused on IPE, the IPE core competencies, situational leadership, and innovative adult learning principles for teaching and learning, such as case-based, problem-based, team-based learning, as well as simulation. But I also needed to include topics such as video and visual methods, as well as content analysis itself. So IPE is considered a solution for the challenges related to safety, quality, and affordability in healthcare. One of my most helpful guiding documents is a systematic review. It was done in 2010, which demonstrated that there were a wide range of offerings within IPE, many modes of delivery, the duration for IPE events, as well as who participated from a professional aspect, were all, there was a wide range. We know, again, that it's valued by learners with positive effects for both skill acquisition and knowledge sharing. But there were some opportunities related to the rigor of research design, improving beyond the perceptions and attitudinal self-rating scales, of which there are many within the realm of IPE. And there were opportunities to inform, to apply theory to IPE planning, as well as doing some more longitudinal evaluation and including the global and cultural influence, which has really come through more in the 2016 update from IPEC. So case-based learning and problem-based learning are also suggested to be great teaching methods for acquiring clinical reasoning skills, which is obviously very important in healthcare professions. Team-based learning fosters critical thinking with a continuous loop method in which students do work outside of class, come demonstrate their readiness, often through quizzes for assurance, and emphasizes the application of teamwork and team performance, and it's facilitator-led. Problem-based learning as you guys I'm sure know, self-directed, open-ended questions and scenarios that embeds new knowledge and skills during the practical application to reinforce the teaching and the students' learning within the group. So CBL, or case-based learning, is considered to be a student-centered educational method that immerses students into real-world problems while simultaneously learning those higher-order thinking skills to apply their coursework with facilitation. I was pleasantly surprised to realize that simulation was used in 71% of entry-level OT programs within the United States, and that it's considered a solution for some of those pressures both on campus and the clinical setting, which I discussed earlier. Simulation and use of standardized patients added meaning and relevancy for students, especially when it's done in an authentic, real-life manner, and helps them to establish those links between the classroom and the clinical setting. IPT draws on case-based learning, so the students really do a comprehensive case analysis that includes both the initial and subsequent assessment and intervention planning. And then it was studied recently by my committee person on the phone to increase confidence, communication, and make contributions to team-based care. Related to content analysis, first I needed to establish that video and visual methods are a common and accepted method within the areas of media, social sciences, and content analysis, and that it really focuses on the message characteristics through systematic, objective, and quantitative analysis, emphasizing careful interaction or careful examination of the human interactions. And what really helped me as I was learning about content analysis is this quote by Babby, saying it says, "Who says what to whom, why, how, and with what effect?" And that really spoke to me related to the simulation experience for the students. So inclusion of quantitative information from a tool, which I'll discuss shortly, helped to add depth to the study and hopefully decrease concerns about subjectivity, as well as we have some qualitative information from the observations. So a conventional manifest content analysis was used for this study. Manifest content is considered subjective, uses visible, tangible, and surface content as the data. So the unit of analysis was the OT student sets of behaviors, and the unit of data is the behaviors that are captured by the tool. And I promise I'll discuss that soon. And I have a copy of it here as well. So in terms of the participants, there was a sample of OT students who participated in simulation that were captured on video, and the CAE Learning Space is our platform that we use at UNE, and that occurred between February 1st, 2017 and March 7th, 2018. It was a sample of convenience and proposive with an overarching IRB in place, which was updated for the study. And initially, because I wasn't able to view the videos until I had the IRBs in place, I did a pilot study of 2 of the teams that I actually facilitated so that I could try out the tool and see what it was like and if it was going to work, as well as provided an opportunity to establish intercoder reliability, which we were able to do with a Scott's Pi of 0.872. And so my guidance for that came from Neuendorf, which is a book that I sleep with almost, that aimed for at least a 10% overlap and a goal of 0.80 agreement between co-coder and PI. So there were 23 videos that were coded by both the PI and the co-coder, and it included a sample size of 21, and luckily for me, they were all the same case, so I didn't have an additional variable to be concerned about. So the tool, as promised, is called the Interprofessional Collaborator Assessment Rubric, or the ICAR. And you can see it has promising validity and reliability, and it was also interprofessionally developed, which is always helpful, with colleagues from medicine, rehabilitation, and nursing. And that there are 5 main principles that really aim for the flexible tool that it is. It does not matter the program or the learning context. It did not correspond to a specific level or learner or the program of study. It assesses growth both in a formative or summative manner, can be used multiple times and repeated, and it can also assist and assess with students who are not making competency for remediation purposes. It is based on Canadian competencies, which of course are different than the US, but they include communication, collaboration, roles and responsibility, conflict management and resolution, and team functioning. And there are 31 statements, and they're measured on a 4-point scale, which will be important as we go on. So 1 is minimal, 2 developing, 3 is confident, 4 is mastery, with 0 being not observable. So for the purposes of the data analysis, I focused on the 3 domains that overlapped, those being communication, roles and responsibility, and team functioning. So this is an example of the communication domain, and I realized when I got here, the slide's a little fuzzy, so if anybody wants to look, you're welcome to. It has all 6 in there. But the way it's established is you have notes at the top that kind of give you the definition of occasionally, frequently, and consistently, and then the overall definition, and then it breaks it into 2 different dimensions for respectful communication and communication strategies, and then you're able to rate at the 1, 2, 3, or 4 level. And so I found the statements were really helpful, and it helps after the pilot study to just kind of sit with the co-coder and really make sure that we are interpreting things in the same manner. So there are 7 behaviors for communication, 7 for roles and responsibilities, and 5 for team functioning. So in terms of ethical considerations and data collection considerations, so the IRB was submitted and reviewed. It was deemed exempt at my home institution, which satisfied Creighton's UNE IRB external review process. The videos were only reviewed after those approvals, and the system, the CAE learning space, is encrypted, and you need a log on and password, so it's limited access. I assigned all of the students randomized numbers and pseudonyms to protect their identities, and there were no adverse ramifications for any of the OT students. It's not a graded experience, and I actually didn't have them again in class. I just teach in their first year. The data remained secured, double locked, and protected throughout the process. Initially, there were 105 videos, which sounds like a lot, but sometimes it was just short videos, or it was also things that weren't simulation. So all in all, there were 23 viable ones where OT students were participating. As mentioned, we did a pilot first, which was, again, helpful to really test the tool to make sure it was going to function in the manner that I wanted it to. And then we input the data into the Excel spreadsheet. And as I mentioned, it was focused on the shared competencies between the 2 countries, which made the 31 statements down to 19, and I'll be sharing some descriptive statistics shortly. So with the PI, we did come up with some qualitative findings that we thought were very interesting, at least to us, that there were some very consistent behaviors, things that we knew without a shadow of a doubt were going to happen. For instance, the students introduced themselves, whether they were asked or did it spontaneously, they explained their OT role, and they were very good about both opening and closing the encounter. The simulations are 12 minutes in length each, and it happens twice in one day and then twice again in the second day, so there's 24 minutes times 2. We also note, and I'm sure this is consistent with ULC and educators as well, that student personality plays into things as well. There are students that are just more at ease and confident in their mannerisms, and there are others that are a little bit more reserved and a little more passive in their approach. And lastly, we did notice that there were some differences in our simulated clients. Some offered information very readily, had a wide range of emotions, whereas others, again, were more reserved. And these are intentionally improv actors, so they're given loose sets of criteria, but expected to react as they would to whatever transpires within the room. And so we also realized that because we were just focusing on the video capture from simulation, that there were times that student behaviors that didn't get rated might have happened in other experiences, such as their orientation, team meetings, pre-briefs, and debriefs that we did not have on video. So here's an example of one of the tables, and all 3 of them are set up the same way. So because of the way the tool is set up, I use just the competency statements as these items on the side here, because it's difficult to reflect all of the statements. I have the frequency of behaviors, the sum, the mean, and I did standard deviation and coefficient of variation as well. So for communication, there were 7 behaviors that were measured, and the communication domain was the strongest of all 3. It had the highest number of total observations, as well as the highest number of observations for each of those dimensions. And it also had the, because it had the highest observed mean, it also had the lowest coefficient of variation. So this basically indicated that the communication domain, those behaviors were well developed and consistent across the sample. So the range of the means was 2.95 to 3.79. The behavioral indicator that was the lowest was the explanation of discipline-specific jargon and terminology, which, as you think about those 12 minutes, it's a little hard when you're sharing space with 6 to 9 other professionals to get every definition out there maybe in that short amount of time. And the one that was the highest at 3.79 was replying to requests in a timely manner. And overall, there were only 3 occasions across the sample not observed within the overall domain. So again, this is roles and responsibility. It's set up the exact same way. So there are also 7 behaviors within roles and responsibility. There was a higher frequency of not observable in the roles and responsibilities domain. And among those instances where the behavior was observed, the overall score was lower with a wider range of applications, which had slightly higher coefficients of variation. So the means range on this was 2.61 to 3.05. The lowest at 2.61 was the explanation of one's own scope of practice, code of ethics and standards, or clinical guidelines in relation to the collaborative patient-centered relationship. So that mean really falls between the developing and competent range on the ICAR tool, and the highest mean was 3.05, which related to the promotion and inclusion of roles and responsibilities of other necessary health providers. And lastly, team functioning, which measured 5 behaviors. The team functioning domain was 3.27. And it basically demonstrated that the OT students were applying competency behaviors at a competent level. These range from 3.06 to the high of 3.47. And the lowest one was related to recognition or relationship between team functioning and quality care. And the highest was 3.47 with a contribution to interprofessional and team discussion. So these behaviors happened 85% of the opportunities. So these are the domain means overall. So it really showed that promising evidence that the OT students were applying these core competencies. Team functioning was 3.27 overall, roles and responsibility was 2.84, and the communication mean was 3.51. And here we can see the percentage of opportunities where the behavior was observed. So communication domain was 98% of opportunities, team functioning was 85% of opportunities, and roles and responsibilities was 61%. And initially I was slightly surprised by this, but when you look at what the expectations are, again, to slam your scope of practice and your best guidelines from your profession when many others are competing during that time, it's unlikely that that would happen unless you really took the limelight away from the interprofessional aspect. And also, after the data was analyzed, Shelley, who runs our IPEC, indicated that each of the cases is built to address 2 different competency domains, and they were communication and team functioning for the Michael case. So it all came around full circle. So some proposed strategies that I found in doing this project, was the importance of connecting the student learning outcomes and objectives with assessment. So we know sometimes when we make objectives as educators, they don't always measure what actually might happen or what we need it to. And so by linking these 2, we know we can figure out whether we need to quantitatively, qualitatively, or mixed method assess each of the events that we do for IPE. We also use a case collaboration and design as an IPE group, so the IPE champions will sit together and come up with a case and make sure that we are providing space for each of the disciplines to have some sort of role, even if it's a smaller role, or planting some seeds for them to really understand how to nurture their role within the case. And it also lets us identify some of the stereotypes that maybe we don't want to perpetuate with our healthcare education. Resource allocation is always a challenge within higher education, and it really takes a lot of heavy lifting to pull off these events. There's over 120 people that would participate in one of these IPE experiences, and it happens twice a year, so that includes everybody from the faculty facilitators to the improv actors to the students from all the health professions, and we know that funding and resources are always a challenge. Creativity with resource allocation is helpful. Our IPEC has really done a great job of building a sense of community within the faculty facilitators and IPE champions, making sure that the cases are authentic and have a relational component to them. But we need to continue to keep getting that message out. We know we need to do some training in faculty facilitation. We all know that not everybody is a gifted faculty facilitator, but we need to provide opportunities for them that they find value in and that they're willing to seek it out. and be open to feedback. We also need to understand, implement, and assess experiential learning methods. And because each of the health professions has individual core competencies that aren't the same, the IPE core competencies are a way for us to unite us as a healthcare of the future. So this is just a schematic of funding administrative support, which is critical for IPE. We know we need the right facilities and learning context, which until recently has been a real challenge in our university. I'm sure it's quite similar here where everybody's vying for space all of the time. But it needs to be large enough, and for us, we have a new simulation center that's equipped with the cameras and this learning platform, so it's very helpful. We need IPE champions, so people who are really going to take the weight of this work on their shoulders. We need some protected time to do it in, whether that's formal or informal. We need a shared vision. IPE experiences that are real and have a relational value, and that sense of community is very important. I also brought the teaming aspect into things because I think, especially given this program, it's really important, and I had a conversation early on as I was developing this project with my advisor, also in the room. And these are 4 components that I did draw a parallel to with simulation. So they include a psychological, technical, motivational, and enabling component. And Amy Edmondson is obviously known, especially in the business world, for her cross-industry collaboration, but she's done some work within healthcare as well. And so basically the psychological safety, the shared expertise, promotion of learning, these are all things that in simulation we want students to lean into their discomfort. We want them to be curious. We want them to ask questions. We want them to take risks and make mistakes. We want to highlight our commonalities and differences and participate in that teaching, learning, trial and error, and debate. So we know that IPE is resource intensive. We know that the time that we spend on the case conceptualization and design is really important, and we can't shortchange that. Again, linking the objectives to the assessment is really helpful, making sure the case is comprehensive in nature and that there's enough different components to it to engage those learners, regardless of what profession they're from and what level of learning they're at. And that we know that if we spend time on the front end with their team building opportunities and orientation, that we hopefully will set them up to meet the desired behavioral outcomes. I think that IPTE is very unique because it's case-based, team-oriented, and has a comprehensive experience that includes the simulation component, which for me is what really inspired me to want to become one of the IPE champions, work with this group of people. We know that support's provided in kind by so many stakeholders, and we provide the opportunities to experience pre-brief, debrief, and reflection through video, and that it's dynamic in nature. We're always adjusting IPTE and responding to feedback from our stakeholders. So for proliferation of high quality education, in order to further extend IPTE, we need to have great cases that are collaborative. We need to garner resources and support of our stakeholders, have a continuous quality improvement process that's linked to our assessment protocols, and make sure that what we're doing on campus really does carry over to that clinical community. So I drew a parallel with situational leadership as my leadership theory because it acknowledges that knowledge and expertise and solutions can come from any level within an organization, and that the 4 styles of directing, coaching, supporting, and delegating really happen in that simulation component where students are switching their, whether leader or follower in those moments, and how they're engaging with their, with both the caregiver and the client. And that situational leadership takes into consideration the relationship between leader and follower, as well as the developmental readiness of that follower. And we know that situational leaders recognize what followers need and adjust and adapt their leadership style to meet those needs. So the parallel is strengthened by the fact that the faculty facilitators really just facilitate. They're not looking for solutions and giving answers to how to best approach the case. There's fluidity for the students. They have to adapt to the situation because there's some progressive information that's revealed over time. And they need to have open communication both with their team members as well as with the clients and caregiver. And the leadership comes from within their team membership. And again, those are learners at all levels, including undergraduate and graduate healthcare students. And context is really important to both OT education as well as leadership. And we hope that this will prepare healthcare students for workforce readiness. So there's a million different ways I think that this research could go. So we know we need further dissemination of IP. We know it is the current way to educate our healthcare students, and luckily I feel that IPTE is an ongoing comprehensive IP experience. It's been implemented since 2014. There can be stronger theoretical educational framework connection to strengthen that available IPE literature. The same type of content analysis using the same tool could be applied to our other disciplines that we have on our campus. And if there was a weakness found in a competency, the didactic or the case or the simulation could be tweaked to address that area if needed. We could extend the video capture beyond the simulation to include some of the pre-briefs and debriefs and team meetings. And we could do a further study to see if OT students really did see the value in IPTE in terms of how it helps them transition to the clinical setting. So this study helps to begin to address the gap in literature related to the application of those core competency behaviors. It adds credence to a well-structured and conceptualized IP experience, which I think IPTE is. And it provides some theoretical underpinnings to guide the positive outcomes. I've just sort of reiterated those three different domains that were studied, the percentage of opportunities and the mean overall. And that the OT students demonstrated competency in the majority of the behaviors and excelled in the two domains that the case was actually built to emphasize. And that hopefully that will provide them with a strong foundation as they transition from campus to career. Lots of people to acknowledge. Hopefully you all see yourselves way there up at the top. And then a whole bunch of people, including the very kind Dr. Curran, who was willing to give me permission to use the iCar in a manner it hasn't been used to watch videos.
Thank you. All right, well, then the next thing we'll do, if you would go around the table first and just say who you are, which I should have done before she started, but you'll do that quickly and then we can do questions.
Okay. Sorry. Hello, Dr. Conrad. This is Jennifer Moss-Breen. I'm faculty member and program director in the program, and also Liz's advisor.
Yes.
I am Candace Bloomquist, faculty member in the program.
Jim Martin, faculty in the program.
Thank you. And on the phone is Dr. Shelley Cohen-Conrad. So who would like to go first?
I will. I just have some kind of high-level stuff. Good job. Thank you.
Thank you.
Thank you very much. I hope, so some just general things. So is simulation used across, like, with Creighton and our IPE area? Is this a very common thing?
So it is more common. What is problematic, which is something I feel like occupational therapists suffer, is the commonality in language to explain, you know, for instance, what occupational therapy is. The same holds true, I think, for simulation. So it could be virtual reality. It could be defined as watching video cases. It could be a high fidelity mannequin that's able to change blood pressure, heart rate, respiratory status. So I think it's important that we compare apples to apples and really get on the same page about what simulation is. So simulation is definitely used, as you saw even in the early 2000 teens, in the OT program 71% of the time, but that did include some of those other things that weren't just simulation. So along with that, we have standardized patients. So think about the OSCEs where someone has a specific list and all four of you who were standardized patients would respond the same way. Your pain would be the same, your symptoms would be the same, versus a simulated client where we're allowed to do some more improvisational things. They don't have to remember what their cat's name is. If they don't have a cat, it's okay for them not to have a cat. So I think simulation really is helpful, and as I mentioned, there's a lot of research out there how it helps to alleviate both the on-campus pressures of space and time and providing those experiences, as well as the clinical partners that are also just overrun with all of their commitments and pressures between reimbursement and productivity.
Okay. And then were there any med students?
Yes.
Okay.
Yes. So there's a plethora of literature. My literature review chapter is quite lengthy. And often, I would say the people who are best about writing and putting literature out there, it tends to be pharmacy. I think it's part of their accreditation standards that they're really putting it out there. Medicine, certainly, as well as nursing, is often involved. And then rehab's another large component, but a lot of it's driven by who's on campus, because everybody who educates health professions, they all have a little bit different chemical makeup of who all is on campus.
Mm-hmm. Okay, that's good. That's good to hear. I don't know if they do med students and OSCEs. I think they do here, but
I think they do.
I think they do, but okay. Let me see. So I'm just trying to picture you doing this. So there was all these videos, and you sat down and you were looking for all the competencies. So how many times did you have to watch? Like you said, you got it down to 23 usable videos or something like that. So you would watch them several times, right? Like you'd be looking for competency number 1, 2. Is that how you did it, or?
So what we did was, again, we didn't really know, again, when we did the pilot, what's really on the videos. Is this tool going to work? There is another video tool that is already out there called the Packed Video Tool that's put out by, I believe, Washington University, but it's really built off of the Team Steps program, and so our students get some Team Steps in their orientation, but it's not in depth, and it's not really what the simulation's about, so it wasn't a good fit for a tool. So the co-coder and myself sat down and watched the videos sort of in the same room and sort of figured out, okay, what are we going to do? And we did actually mark down how many times we watched each of the videos, but most of the time we didn't need to watch them multiple times after the pilot, because we knew what we were looking for. We had an expectation of, and the way the tool is written, it was actually easier to score than I might have thought initially. And then we were able to just, so they input the scores into Excel and went from there.
Okay.
So I was worried I was going to have to watch all the videos like dozens of times.
Yeah.
But because the simulation is 12 minutes in length, and I was only watching the 12 minutes that the OT student participated in, that's why I went from 105 to 23.
Okay. And in your dissertation, did you go at all into conversation about simulation versus practice, actual practice, what real world, or was that may have been outside the scope of what you were talking about? But
so
I'm just curious.
We tried to make some links into, coming most recently from the clinical world into academia. I'm still sort of a higher education baby in terms of that. For me on the face, it looked like a great experience that I could see being very translational. And so that's why I was really glad to be able to do this, to sort of see what's even happening, because I only had the lens of what was happening in the simulations that I was the team facilitator on. But you never know whether you're a good facilitator or a poor facilitator if that's happening in some of the other videos. So I appreciated being able to see all of the teams, and in the simulations you don't actually know who the faculty facilitator is. I think the next step would really be to see, for the students who participated in 50, did they actually see a value when they went on into their clinical career?
Yeah, that'd be really interesting.
So I think that's the next step.
Yeah, interesting. Okay, good, thank you.
Sure.
Thank you for your presentation.
Thank you for being here.
So the big overarching problem that we have that simulations are trying to address is the safety, quality, and affordability of healthcare right now. Like, this is a big problem within the United States. Of course, many other countries have similar quality, affordability, safety issues. And then you also mentioned the stereotypes. So we don't want to perpetuate stereotypes within the team, or the stereotype of patient stereotyping.
It's really more within the team itself is the direction we're coming at, because strange as it may seem, we all think we know what a pharmacist does, or we all think we know what an occupational therapist does, but most of the time the students who are in there trying to learn their own identity in their profession haven't made those connections yet to that clinical world to know, wow, pharmacy does so much more than I thought it did, or OT is such a broader application than I thought it was. So it provides that opportunity. But it also is the stereotypes for patients as well. So as I mentioned in the Michael case, there's a lot of those social determinants of healthcare, because that's what we have in common, regardless of our health profession, that If somebody doesn't have access to care, it's a problem. If they don't have transportation, it's a problem. If we make judgments about the fact that they don't show up for their appointments, or they don't take their medications, or that they're using recreational marijuana or alcohol as a self-medication, we need to figure out what the roots are of those problems. And so that's what these simulations have been really helpful, is providing students how to have that difficult conversation, or how to ask that open-ended question in a non-judgmental manner versus assuming something is normal because that's what our frame of reference is.
Yeah, and you mentioned that, you know, simulations and standard students were developed to hopefully address stereotypical perpetuation and the safety, quality, and affordability, but also because the clinics are getting tired of having students run through their doors and affecting their patient care on the ground, right? And you talked about the quote from Valley, that, you know, it's like, who says what to whom, why, how, and with what effect? So with the simulation, what's the effect? Like, so you mentioned in a couple of the resource allocation circle and the teaming squares, right? That there's a step called shared vision. And what's the direction, alignment, and commitment that they're all going toward, and how do you assess that? Because you've assessed, these are all processes.
Yes.
Communication,
Yes.
team functioning, roles and responsibilities. Like, and you said they're all competent, you know, which they go out there and they're probably not all going to be competent.
Correct.
Right? What's that bigger outcome? How are we addressing safety, affordability, and quality with these simulations when we're not looking at, okay, the standard patient Michael could go one of two ways depending on the team's ability. Like, they could fail miserably, which if a simulation is doing well, there's going to be sometimes that the entire team fails miserably because we know that that's reality and we need to mimic reality if we're going to do simulations. And there's going to be sometimes when Michael gets the care that he needs holistically and the team together has done that. If there is never an opportunity for simulation to fail, are we doing simulations well?
Yes, so there definitely are opportunities for failure, and I've had the pleasure, because I think these are always an opportunity. I always know in my own life I learn so much more from my mistakes than when it all goes smoothly. My path is always one that's like this instead of straight. So the simulations are just one component of this semester-long experience. So they start building their team the moment they walk in on the first day for a 3-hour orientation. And during that orientation, they do some team building exercises that I'm sure are quite similar to things that your IPE center does here. They are put together totally randomly to try and evenly distribute our health professions within those groups. But then they do things like come up with their team name and have to explain to the rest of the group as to why they chose that team name. So it's sort of setting some of their shared vision with that, if they do it.
So coming up with a team name, how is that creative vision for what they're trying to do? So
Again, so
who says what to whom, why,
Yeah.
how, and to what effect? Do they know why they're setting a team name and what that vision
they
is
do.
that
So
they're trying to do?
as part of that activity, the prompt is to collectively come up with their name based on their future healthcare provider self and their aspirational goals. So as a team, although it's a creative opportunity, they're coming up with collectively, usually it's a team name that reflects the type of care they're hoping to provide. So maybe it's a comprehensive collaborators, or they'll use the names of all, and I forget what the name is, they'll do an acronym based on, you know, PT, OT, social work, whoever's in their group. And so they're setting that shared vision of the type of care that they're hoping to provide in that moment. They're also coming up collectively to determine what makes a good team. They share their team experiences that they've had in the past and what went well and what went poorly, and what a healthcare team should look like. So it should be patient-centered, for instance, and have a positive communication loop and all hear each other. So they're starting to come up with some of those before they even get the patient case about what the dynamics are going to be. Does that help answer your question to some degree?
I'm so curious about how the simulation helps with those safety, quality, and affordability. Yep. So do they ever think about, as we work as a team, that this care is going to be more affordable to the patient, that the cost of healthcare in 5 to 10 years is going to drop dramatically? Otherwise, how are we impacting safety? How are we impacting affordability by just doing, like, because
Yeah.
there's lots of different exercises that you can do to help students communicate. Like, okay, that's the procedural part. But if we're never going to make an impact on the outcome, then you said that doing a simulation costs a lot of money, a lot of people time,
Right.
a lot of all of this, with the hopeful desire of safety, affordability.
And so with the cases, they have to, as part of the team steps component, they do a pre-brief and a debrief before and after each of the simulations. And they have the opportunity to reflect on, okay, it sounds like Michael's goals were X, Y, and Z. I'm from California, I have no idea what there is available in Maine for pharmacy, or for transportation, or for VA services. And so after that simulation day, they have a second simulation. So they have a week in between where they most likely meet in teams and figure out what are the options for Michael to make his needs met. Okay, this is a free program, this is a sliding scale program. And even if they don't end up practicing in Maine, going through the processes of finding what is it like to apply for Maine care in our state, which is a cumbersome process with lots of forms. So if he's not literate, we need to get him some resources for that. And so I think that gets at some of the affordability components of how do we problem solve this case that has so many different dynamics within it. How would I approach that? How realistic is it to have all of our professions working together? Would this actually be a thing in real life? Or might it be that these two professions really take the lead on that, and here's why? Or this is going to be most cost effective if we don't have him have his teeth cleaned right now by dental hygiene or dental medicine, but we focus on these other two professions that are really going to meet his immediate needs, and then make that longer term plan.
That was interesting because the that resource allocation slide that you have where you're talking about each of the shared vision, kind of let's do that fast.
Oh, sorry,
Like,
I didn't mean to.
Shared vision, something, yeah, and then going on, right?
Yeah.
And that's, I think, a very important aspect to this, not only for the students that are experiencing it, but for the faculty who are trying to facilitate it. If we're just perpetuating the same thing and just calling it a different name, are we reflecting on the experience of, we're not talking about affordability for that one individual, we're talking about affordability of the healthcare system.
Right.
Right, and sure, like, if we have to have 9 different healthcare professionals on every team, that is not going to be affordable, right?
Correct.
And so how are we as a system being able to make sure that we have safe, quality, affordable care always available for every individual? And how are simulations helping to do that? Or at least how are the faculty reflecting on, you know, the whole, and I understand that this is only part of the overall, the educational experience that the students have.
And
but I think if we're not thinking about to what effect, because you observed this, you only observed ones that were successful, like everybody was competent.
So the numbers are confident, but some of the students were not observed to do the behaviors. So instead of using the 0 value, we have a not observable. So there are times when the students didn't exhibit the behavior, even though the overall mean makes them in the competent realm. Because it's team-based, it might be that one of the more reserved or quiet students, more passive students, is carried by a team member, for instance. And the students do provide feedback, and it's a continuous feedback loop. So they do what was their ability beforehand and after, as well as part of this cycle. And then this is also the 3rd case that I have been a part of. We just did our 3rd case recently for IPTE. So it was nice that all of the students that were in my sample had the same case instead of having multiple cases. But we're constantly kind of adjusting those to hit different contemporary problems that we're seeing that are reflective of what our students are going to see, to try and address some of those same issues.
Yeah, and I liked your ideas for future research. And I would say, like, keep looking for examples where there's a complete failure and observe what it is. Because I think you'll see the exact same things when something fails as you see when something doesn't. And we're not, and I think this is collectively, I don't know that we've quite understood what it is that's that secret sauce
Right.
Because it can't, because people are communicating, but are they communicating the, what are they communicating, right? And why are they communicating? They're communicating, look, consistently. So you have to look at that, right? And they're consistently promoting their responsibilities, right? And you can still have a massive failure at the end, right? Where,
So one of the questions I always ask on the Michael case of my team is, do you think Michael will return for his next session? So they can identify on that continuum, did they fail and not meet his needs and actually at the end of the simulation not know that his biggest issue was pain or the concern for finances to buy his recreational marijuana? Did they miss that entirely? And so as faculty facilitators, that's an opportunity to ask some of those open-ended questions back to them. Or in one case, with the Michael case, he has these really painful legs from his injuries from service in the Vietnam War. And the students had him sitting on the edge of the bed, unsupported at his feet or his back, and he was dangling and very much giving the nonverbals of, I'm really uncomfortable, and they totally missed it. And so it provided an opportunity for my co-facilitator and myself to have a team meeting with them, have them sit in the same manner, ask them as healthy, younger individuals, how comfortable they were, and show them the video of the nonverbals that they missed. And so I think having the video capture is really critical and encouraging the students to take the time to watch. No one likes to see themselves on video. I'm for sure the one that don't like the sound of my voice, don't like to see how my hair looks on any given day. But it's really important because that's the best learning tool that they have because they can really see it in action and find out where their missed opportunities might have been. And so that was a really good opportunity for me to see a failure, potentially that, I mean, unless we were paying Michael, which we were, to come back the next week, he might not have returned for that care because his immediate needs weren't met and he was uncomfortable during the session. So he's having trouble getting to the appointment. Why would he want to come back?
I just think it's that reflective part. It's probably one of the most important part, and neither the Canadian
It's
one
not,
nor
Yeah.
the short one includes that aspect in one of the competencies.
And so another piece that's developed over time is the students get feedback from the improv actor. So they get a chance to hear how their team did, what were the opportunities that made them feel most comfortable, or maybe were very uncomfortable for them. We've recently changed that so they get that feedback in their small team because nobody would want to be called out in a large team of 120 people to say, geez, you know, Liz, the OT, you seemed really dismissive to me. But in a smaller group of 6 to 9, yeah, you probably do want to hear that feedback. And so that's been a nice part of the quality improvement that's continuous and that's built into IPSI is that opportunity to make that shift, to make it more meaningful for the students. And then the next time they meet, it's a big group where they get to talk about how it felt to go through this experience and really do that reflective component after they've watched it.
Now you're getting at how it goes. Now you're getting at to what effect, right? And that's what I wasn't seeing as you were going through, and I think is an important part. It's to what effect is any of this? Like, we can communicate, we can function, like, but to what effect? It's that reflective piece, feedback from the actors.
Yeah.
You know, it's all of that, and so I think as you continue on, which is great, as you continue on, make sure if you do another content analysis, to what effect, and have that aspect in there as well.
Yeah, and I think it's great to springboard off of it because I think first we needed to show that they were actually demonstrating the behaviors and applying them in the simulation. And so now that we know that there's potential that they are, then I think we can go to that next step of the effect component. And does it last? Does it last just while they're on campus or just in the 6-month period or 18-month period? Or does it really carry over? Like, that was a really transformative experience for me and it's going to inform how I interact with all clients from here on out. That's pie in the sky, I realize, but I think until we know that, we don't know the true value. And I think for me, this has been transformative for me because I am a new educator and I think it's always really important that we, even if we think an activity is great, that we have to step back and make sure it's great for the students too and they get something out of it that actually lasts and has a meaningful impact. And so I think that that's really important for me and something I think can be difficult for people that aren't necessarily on board with IPE or aren't comfortable with the simulation or aren't comfortable with the faculty facilitator not just saying the answer is X, just focus on X and Michael will be fine. And so I think that that's been a really helpful part for me, and just connecting back to some of the educational theories and things that I didn't learn about in OT school, but that I did have the opportunity to learn as part of this program and kind of go further into that as well.
Okay.
Are you going to present this elsewhere?
Likely. My committee and chair think that I probably should.
Yeah, I think so too.
Yes, my plan will be, I've presented before at Collaborating Across Borders, which is an IPE conference that occurs annually, not on this particular experience. And I work with a team of IPE faculty on another event, and we often present that as well. So between occupational therapy being very interested in IPE, and IPE being a strong concept in contemporary education for healthcare providers, I think that I probably will.
So if you do that, and you'd obviously reframe this presentation because you wouldn't have to, some of the detail would need to be there. But on the tables with the
Yes.
statistics, you need a much bigger font.
Yes.
So always, no, it's just, you know, if you haven't done this kind of stuff before, then that's kind of how it is. So, you know, always consider, like, in a room this size, somebody who's sitting back there, being able to see
Yes.
everything, you know, functionally without like being like,
Squinty,
what
yeah.
is that? You know, because you want to speak to it, but you want them to be able to see the different parts and stuff like that too.
Yep. Thank you. That's helpful.
And then I just have one question. So in your kind of conclusion slide, you had training faculty facilitators. Can you go back to that slide? So it was in your recommendation.
Yeah. I'm trying to get to it.
Maybe it was before that. Proposed strategies, yeah. So and you mentioned these things, and you said, you know, that improving that would be an element of that. Upon what element of your evidence are you basing that?
So some of it relates to everybody's drawn from this different pool of health professions. And I think some professions sort of lend themselves a little easier to some of the facilitation. But having participated in IPDE since it started, since I started at UNE in 2014, there are some faculty who really have a hard time stepping out of the diagnostic role of wanting to come up with the answer is this particular diagnosis, and this is how we would treat that diagnosis. And there's other people that draw more from the psychology and psychosocial realm that have an easier time addressing some of those more basic needs. I think we just know that we're not that we all want to facilitate the same, but we also have a group of people who are kind of stoic facilitators, so they literally just kind of hold space and time in the room and don't facilitate.
And so
there's
that's based on your experience of having observed this process. But did you observe that dynamic in this
not in the
study?
simulation.
Okay, so my thought would be, you know, that's certainly an implication,
Right.
but it's probably not based in the evidence of your study. So you might want to move that
Into a future direction.
to something
Yep.
like that, because
Right.
it's something that you've observed,
Great.
but the literature perhaps the literature supports that.
Literature does support it, but you're right in terms of
If
it
you
being
didn't
focused on the
observe it,
simulation, because
yeah,
facilitators aren't in the simulations themselves, so
Yeah.
that's helpful.
And similarly, on the resource slide, what's that based, resource allocation slide, what is that based on?
So
And again, like,
saying it's more just, yes, it's.
yeah, bigger font.
Some of this didn't translate as well from the dissertation tables and
Sure,
to
yeah,
the
yeah.
PowerPoint, but it's important feedback and certainly helpful. So really it's based off of literature following now we've done the simulations, now I've done the descriptive statistics and what is almost like coming back to do another miniature literature review based on the time period from having written the original literature review to now, and that these are really the things that are coming through very strongly as, again, with some of those future directions. And so when thinking about how do we continue to proliferate high quality IPE, these are the things that bubble to the top. And so there was a lot of crossover with what IPTE is as well.
So maybe some sites in there to support that dynamic.
Sure.
You know, so as it flowed to me, it was kind of like, so is this just something that's already in place that, you know, fits this, you know, or what is it, you know, that's native to your institution, or is this some new direction that's based on the literature and the pieces? And this may be in your dissertation. And
I would say it probably is strongly in the written document, but it's
Yeah.
not being strongly reflected.
Yeah, so that connection wasn't as evident to me.
Yeah, very helpful.
So, because the next slide was the teaming, then you're like, okay, so connect that to the teaming literature, and that made sense.
Yep.
You know, it's like, okay, we need to consider these things. Yeah, okay.
I think that's probably more well-developed in the written document, but it certainly can be expanded for this purpose. I appreciate that.
Yeah, because I mean, if in a presentation to an external audience, these things would be the big takeaways.
Correct.
You know, like you'd kind of, hey, here's this problem, here's what we did, here's simulations, we did it like this, real short methods, and then go into this stuff, really what you found and what you recommend. And so you want to punch up that connection to the evidence and the literature a little more strongly in the presentation. But thank you. Yeah, interesting stuff. I mean, because I think, you know, similar to what Dr. Bloomquist says, you know, people talk about this, you know, IPE or interdisciplinary leadership, you know, all the time, and teaming type dynamics come into this so often, and everybody seems to think it's a great idea, but what are the outcomes? You know, like, and I don't think that, you know, that's as well established of tying, okay, so we're putting together these things, what does that do? And, you know, similarly, we had a dissertation recently, or I can't remember who was talking about it, maybe it was Dr. Georges, but so medical schools are training people like this and then sending them out to places, and the hospitals are like, what in the world is this person trying to do?
Yeah.
You know, because it's almost like that, you know, stereotypes about millennial behaviors. It's like these people just think they can come in here and talk to whoever they want to, and there's a chain of command, and there's this and then that. And you know, so, you know, I can't remember, I think Leah brought it up, and we've talked about it in other circumstances, but it's like, are these schools training people for what they are going to experience when they actually go out there? And you kind of touched on that in your answer to them, so thanks.
And I think that is important, because again, if we curate the most perfect experience for learning purposes that doesn't exist in clinical reality, then we're doing a disservice, and we need to help blend the theory with the actual practice, and how to take your ideals that are so important, and we don't want anyone to compromise them, but also work within a system that isn't always built for this.
Right.
Which can be soul-crushing to students who aren't ready for that, and can really cause burnout before they've even gotten a chance to really start their career. So I know it's a big consideration and concern for me, especially as OT is considering moving to an entry-level doctorate, full stop, which is similar to what physical therapy did several years ago. So it's that, how do we prepare students for kind of the ideal, but also the reality?
Good. So, and that reflective piece, so that they know why they've been trained this way, because it's about, like you said, that they're ready to go into a system. No, I want them to change that system.
Yes.
And it takes a lot of perseverance in order for them to go in, knowing why they've been trained this way, to be a reflective practitioner while they're out there, to be able to take the surgeons, that she was talking about, surgeons, that were, like, can be mean, to other professionals, that they're strong in their conviction that this is why I'm doing it this way. I can articulate why I'm doing it
This is why it's better, safe, and affordable, and all of those.
and this is how it's going to help. And so you can like that they have to kind of be prepared, or else they will burn out. because they're going to get that, right? And so it's about their alignment, their understanding, their direction, and their commitment to that something. Yes. And we're having a hard time within higher ed to be able to help them to articulate, because we don't know what our healthcare system should look like. We just know that this isn't the right one. Right? Right.
So another component that's not simulation that IPEC does is they provide an opportunity for students to present on this experience, as well as other IPE experiences, and they can pursue an honors distinction, which requires them to write 3 reflections on 3 different IPE experiences and connect them to the competency. So it's multi-layered, and I think they've done a really, Shelley can close her ears if she directs IPEC, but I think they've done a really good job of connecting that reflection component. It just wasn't necessarily the huge focus of it, but it would disservice to not share that this is also a component of it. And at least for OT students, about half of them pursue that distinction, which I think is a pretty good amount of our students.
Trying to butt in here.
Based on what you've asked, Dr. Bloomquist, if she does, we anticipate she will not only present, but hopefully submit for publication. Do you think that it sounds like the explanation of the contextualization of this particular component of experiential learning didn't come through in the presentation? If she adds a slide about that, because it's clearly part of a larger educational experience.
Yes, yes. And I came back to the learning objective, right? And the big why, because I wasn't clear on the big problem. Are you talking about simulations are helping to develop a system of healthcare that's more safe, more better quality, and more affordable? Or are you creating simulations to take the burden off of clinics? Which is it? Like, because I think the more proximal one, which you're talking about, and which higher education is getting pushback, is the clinics don't want to do this anymore, so we need to find a way to create an environment where they can learn these things, so we've created simulation. I would like to see the connection back to the bigger problem, right? And not just clinics have trouble billing, they're taking time away from patient care, and so they're not giving their payments, so they don't want these students in there anymore. So we're going to bring them back into higher ed and practice them up a little bit more here using simulation. So just making that, which problem are you addressing? If it's just bringing them back into higher ed, okay, fine, do the simulation. If it's trying to address that bigger one, that reflective piece has to be in there, because we have to know what that outcome is that we're looking for, and how this practice, that learning objective is, you know, yeah, sure, if we're just taking it away from clinical situations and putting them back into higher ed, scope of practice, networking, communication, professionalism, and dealing with medical errors, that's doing that, right? If we're trying to address that bigger problem, affordability, safety, equality, are simulations getting us in that direction? Not without the reflection, not without giving them the opportunity to see how their communication, how their professionalism has impacted that clinic. Because the Canadian one, and I spend a lot of time in Canada, has collaboration with the patient, client, family as one of its core competencies, right? And the U.S. one doesn't have that. And I'm experiencing that right now with my family. The doctors and the nurses are communicating at, but not with family is not understanding, right? And that's a big part still. So I think, yeah, being clear about which problem you're addressing and seeing that line of sight down to, okay, then these are the learning objectives. If we just took it out of the clinical practice and brought it back into higher ed, if we're trying to address those, have to have some talk, some discussion around the importance of that reflective piece, where they get to see what impact that process.
She does a good job of that in the dissertation, but that definitely was not an emphasis in the presentation. But like I said, we are hoping she'll take it forward. So that's a piece that we can add to that.
You take the dissertation down to something.
Yeah, and Debbie will tell you, it was hard to take this to this. And I knew, even I'm like, oh gosh, and Dr. Martin just recently wrote about how to do a PowerPoint, and I'm not doing the way it should, because it was so hard. and I kept saying to Debbie, this is really hard to take this down to this, but it's really important, that feedback, because you look at it so many times yourself too that you sometimes can't see it anymore. And what looks okay on your smaller screen clearly didn't come through as it could on the larger screen. So that's helpful.
That's learning.
Just helpful, yeah.
It is the Jesuit practice of discernment.
Yeah.
That is best at the end there, yeah.
Dr. Cohen-Conrad, do you have a question or questions for Shelley?
Can you hear me?
Shelley. I'm talking to Shelley. Oh my. For Liz?
Can you hear me? I don't think you can hear me.
I can barely hear you. I don't know how to make it. Try it again. Okay.
Whoa, can you hear me now?
Now we can.
Good. Okay, because I think, you know, Liz pretty much addressed everything I was going to ask about, but I'm listening to Dr. Bloomquist and others, and I think in the dissertation, you do a nice job, Liz, of addressing sort of the culture in which the simulations are just a part of, and that the students they're exposed to advocacy, they're exposed to the kinds of population health problems, the kind of healthcare problems there are. So I don't think that came across in the presentation as much as it does in the dissertation itself. But I think these are very provocative questions, and I do think that you can't do simulation in isolation. I agree that it doesn't hold any meaning. It has to be part of a broader continuum of learning. So, Liz, do you want to add anything to what I've just said about the culture in which the simulations are setting within, or do you feel like you've covered that adequately?
Well, so that was one of the challenges initially, to come up with sort of the scope of the project, because IPSI is so much more than just a healthcare simulation. But healthcare simulation, I think, is such a contemporary thing, and as I said, it parallels to OT, and where we're always trying to get everybody, all of you speaking sort of the same language. And I think the same is true with simulation and IPE. And so it is just one of the components. And so one of the other directions is, do you then study sort of the orientation component and do those team names and other team building activities really start to set that shared vision. In terms of the facilitators, we're all part of that same team in the beginning. And then as I mentioned, we have a really state-of-the-art simulation center, which we went from almost like closet-style simulation to a really wonderful facility that we can really do these things and have the students really engage with people. And they really don't remember that it's an improv actor until they're reminded of that and they say their actual names. We do have to stop them sometimes from, say, looking in the patient's mouth. That's not going to be reflective of the x-rays that they have or reflective of the components in the case. You're not going to see war wounds on legs, that kind of thing. But I think adding the video, as I mentioned, as I said, I do a lot of lab practicals in my OT role, teaching labs, and making students watch their videos of their practicals or watching their IPE is always a hurdle to get them over. But I think that CAE learning space provides an opportunity for students to actually annotate on it if they want to say, you know, missed opportunity, or wow, I really loved how the nursing students framed that question, or I wouldn't have been brave enough to ask the question like the social work student did. So it provides a lot of that reflection. And then I think, again, getting the feedback from our clients, the clients and caregivers, has been an important piece, as well as the larger debrief, because there's so many take-home messages. And even that qualitatively, I love, you know, thinking of those quotes and things that students are like, I realized I don't have to do it all by myself, and that I'm better as part of a team than I am on my own. And that true appreciation for learning from the scope and really kind of leaning into some of those discomforts, because it can take them a while to not just want the right answer, because that's how we're built, is to get the A and answer the right question the right way. So, yeah. Does that help somewhat, Shelley?
Yeah, it does. I mean, I don't want to put you through too much more.
Okay, I'm here.
And it really wasn't an emphasis of the study, but the other piece of the rapid cycle evaluation that the faculty, everybody who designs and works on on each simulation there's a big debrief afterwards, and that changes are made every single cycle to improve and strengthen what we're doing. So there are multiple levels of reflection and debriefing that go into this, but I don't really think that that's what needs to be included in your dissertation, because that's really not what you were looking at. So I'm done.
Okay, thank you. Given we've had some really comprehensive questions, I don't have, at least half of mine were taken care of, so I'll save that for later. Other than that, I want to thank everybody for being here today.
Thank you.
Thank you, Shelley.